everyone. I'm Lauren Sansing. I'm chair of the International Stroke Conference 2026.
I'm Bijoy Menon. I'm the Vice-Chair of the International Stroke Conference 2026 at New Orleans.
So today is the first day of the main conference. It started off with a bang with the Feinberg Award and a tribute to Walter Koroshetz and 3 really fantastic clinical trials in the main event. Maybe I'll ask you, Bijoy, what are you most excited about that you learned today?
No, that's a great question, Lauren. Given my own background, the trial that interested me most was the CHOICE-2 trial with intraarterial alteplase, or TPA, as you would call it. I think, you all know about the CHOICE-1 results, which were published around 5 years ago. And at that point in time, I must say, a lot of us were skeptical whether this would work. We had thrombectomy, which was such a powerful intervention. And the idea that you would actually now go with catheters and sprinkle a little bit of TPA post-thrombectomy, and that this would result in the substantial improvement in outcomes. I was wondering, really? And then you had a few trials from Asia come out showing promise. The CHOICE-2, credit to Dr. Chamorro, confirms what he set about to prove that intraarterial alteplase post-EVT, even in patients who actually have TK3, which means that thrombectomy has done its best, seem to benefit.
Yeah.
What did you think, Lauren?
I was really excited about those results. We've had this long recognition that a lot of patients get reperfused. The main artery, the MCA, will be recanalized, but yet there's this gap in clinical outcomes. And so, the question then is, well, is getting that trunk not enough? Is there already too much infarct burden? And this idea of no reflow or sort of microthrombi and persistent microvascular occlusion, it was an intriguing one for me. So I'm really excited about the results. So as you mentioned, patients, most of them had good reperfusion. They had to have a TICI-2B or C or 3, and then they were randomized to additional intraarterial TPA versus placebo or not. And the benefits were profound. I mean, there was they had a very high bar, right? It's percentage of patients with an excellent outcome, MRS of 0 to 1, and yet there was a really substantial benefit for adjunctive TPA.
Yeah, I think the number needed to treat, as you're pointing out, Lauren, almost close to 6, suggests that this now, along with intravenous thrombolysis and thrombectomy, seems to be, one of the most robust treatments we have in acute ischemic stroke care. What was also, I think, quite interesting, and I know Angel's, he's a scientist. There was a secondary outcome which was looking at perfusion at 24 hours. And it clearly shows that there is, reduction in hyperperfusion at 24 hours. So mechanistically, it's actually showing that, that the no reflow phenomena is a biological target and that TPA seems to work.
Right. Yeah. And I think what was also reassuring is that so many of the patients had already gotten IV TPA. And overall, the safety data looked okay. There was a small increase in mortality in the treated patients. That's taken into account when you're looking at the modified Rankin scale score, and still there was overall the benefit.
Yeah, and that is, though, one point that I would, want to still consider, because the mortality difference is still 6%, so 6% versus 12%. And so the overall implications of this treatment, while it improves, patient outcomes on the left side of the Rankin scale, it potentially may cause harm on the right side, is intriguing. And so I think, there's something more to be learned. Angel is looking at this in some, specific subgroup analysis. What is also interesting is that the increase in mortality cannot be explained by symptomatic ICHs.
Right.
And so that is an intriguing finding. So I think, there's still some things to be learned before all of this can actually be translated to practice.
Right. And yet we now have our phase 3 randomized clinical trial showing benefit. So
Lauren, the other trial on which, over the last so many years, this has been one of the things that I've been interested in and hoping that we would have a treatment target is intracerebral hemorrhages.
Yes,
And so
indeed.
what did you think about the fastest
The
results
fastest
that
trial,
Joe and
right?
Kazu presented?
Yeah, so kudos to them for, pulling off the successful enrollment and randomization of such a large number, over 600 patients in the pre-hospital setting using mobile stroke units, and then randomizing patients who are presenting very early after ICH to recombinant factor 7A or placebo. And, it was obviously the study design was changed at the recommendation of the DSMB after the interim analysis, because overall there didn't look like there was going to be efficacy, but two clear subgroups stood out. And they also make sense, so it's the super early presenters, less than 90 minutes, and those with a positive spot sign, which we've known for a long time is a nice marker for ongoing bleeding. So those two also, you like things that make mechanistic and biological sense. And so now the trial is going on in FASTEST-2, looking at just those two subgroups, positive spot sign within 120 minutes and those at less than 90 minutes.
Yeah, I quite like what you said, though. Sometimes you wonder whether these subgroup results, are just subgroup results, that they are random, right?
Right.
But in this case, there's a biological rationale for it. That is in the super fast comers and those who are leaking, the spot sign positive patients where there might be benefits. So I'm excited that, hopefully there is continuing trial would actually show some positive results in intracerebral hemorrhage with hemostatic therapy. I must say, though, that this was an incredibly difficult trial to do, having patients within 120 minutes. And the fastest trial is a testament to international collaboration. The Japanese enrolled almost close to around 250.
Yeah, and they didn't have a waiver of consent, emergency consent. Yeah, and they're still the largest enroller, so that's amazing. Yeah. But I will say that unlike, when we have primary results papers and we're looking at those secondary endpoints, pre-specified secondary endpoints, and we see these subgroup analyses that show benefit, I'm always hesitant, right? We've been led down the wrong path many, many times looking at those. But this is going to go on, right? So they're now actively randomizing those two groups. So we will get an answer.
Yeah, this is how fine should be, I guess, right?
Definitely.
So subgroup analysis, and now there's the
roll right into the next phase, right? So adaptive, adaptation in real time for a trial, and that's really exciting.
And I think we had the last trial, which was CREST-2, presented today, especially its cognitive outcomes. We know the results of the primary trial, and I was, excited. Being a neurologist, I've always wondered, obviously we care about hard outcomes, but we should be caring about cognition. And especially with CREST-2, I did want to understand what it meant for patients' cognition when you actually stent asymptomatic patients, right? So what did you think, Lauren?
I have to say that I was hopeful, on the overall trial where there was a reduction in strokes in the stenting arm compared to those that are in the stenting sub-trial treated with intensive medical therapy. So I thought that was going to be like the tip of the iceberg, that then we were going to also see a broader, prevention of cognitive decline. So I was, a little bit surprised that didn't turn out to be the truth. That there was completely neutral results, whether you look at the CEA trial or the PASS trial, and in whatever domain of cognition you're assessing. Clearly, the trial was had long-term follow-up. It had sort of a comprehensive battery. So I think it's a pretty definitive answer for me that that at least in asymptomatic patients using 75% stenosis as the cutoff for enrollment, stenting or revascularizing by CEA, either way, we're not preventing cognitive decline as a whole.
Yeah, no, that was interesting. And then Dr. Lazar presented this idea that in those patients who had indexed incident strokes post-randomization, there clearly was a drop in their cognition.
Yes, indeed.
And so I was trying to make sense of these two results where, overall there's no difference in cognitive outcomes. But clearly, if you had an incident stroke, then there was a drop in cognition. So what did you make of it,
Right.
Lauren?
Yeah, I think so. In my mind, most of the strokes that occurred in the trial were minor strokes. And so clearly minor strokes do lead to cognitive decline. So then in the stenting arm, when you do prevent some of those minor strokes, the prevention, the absolute amount was relatively low. Overall, there weren't that many strokes, but you prevent cognitive decline in those patients. And so I think that's a meaningful result. And, taken as a whole with the overall trial results, it does make you think that in highly skilled hands, perhaps there is a role for stenting in the right patient population. And maybe that will be because you prevent strokes, but you also prevent those long-term effects after a stroke.
Yeah, I agree. I must also, commend the CREST-2 trial investigators for taking on this, what I would say, an onerous task, right? Like
Yeah.
collecting cognitive outcomes in all of these patients. It seems that they tried and they did this via telephone, and that
Right.
they have this slick system now where they could collect all the 5-domain clinical outcomes, cognitive outcomes, in less than 25 minutes. And I think, CREST-2 is one example and an exemplar trial for us, that in the future, when we do these clinical trials in stroke, that I think we should collect cognitive outcomes.
Right.
They
Indeed.
help us understand better what we are trying to do. So
Yeah, which is overall improve patient
that's right.
lives, right? Not
Exactly.
just prevent another stroke.
Yeah. So, Lauren, what about tomorrow?
Well, I am super excited about the main events, and I mean, there's a number of trials that are going to be presented, and then that culminates in Friday, of course, or when we have the most trials. So I think the rest of the conference is going to be fantastic.
I'm excited to. I would welcome all of you on behalf of Lauren and I to attend all these sessions tomorrow. Please also attend the fireside chats with the trialists, where you would learn more about all of these trials. There's also the acute ischemic stroke guidelines and fireside chats. So incredible science for the next couple of days. Thank you. Thanks, Lauren.
Thanks, Bijoy.